It's a pleasure to be here again, and I know that some of this is being recorded, so for those of you who aren't here with us today, I'm sure you'll be able to capture this later on. It's my pleasure to introduce our panelist. Our representative from ACA was unable to attend. It appears that the message from CMS about LIP not being able to go forward in its present form may have caused the state some grief, but we kind of knew that was happening. Linda Wertz is, first and foremost, as far as I'm concerned, a Texas graduate. We're both Texas graduates. She's from the University of Texas campus at Austin, and I from the University of Texas Health Science Center in Houston. She joins us today with an extraordinary panoply of experiences and skills, most significantly relating to Medicaid. She served as the director of the Texas State Medicaid program for 7 years, and she worked within that program for decades, so she's intimately familiar with one of the largest, most complex Medicaid programs in the country. She has since been performing healthcare consulting for privately, and now she is the principal for HMA in the lovely city of Austin, where she's working with the state and with other states, looking at questions about waivers moving forward and surviving in this challenging transitional period of addressing healthcare reform and how to pay for it and what we don't get. So Linda's going to talk about what's happening nationally with a few specific state examples, and then I'll follow up with a little bit of a recap on Florida, and we'll open it up for discussion. And if we can, we'd like to get you all out of here early so you can get back to Tallahassee and get back to work. Linda.
Thank you, Jay. It is a pleasure to be with you today, and an honor. When I was contacted by Ryan and Tammy, I wasn't sure what would be on the list of discussion, but what I'd like to do is talk to you a little bit about the Medicaid expansions in some of the states. I'll give you a little more detail on Indiana, but then I want to focus our attention on 1115 waivers related to DSRIP. How many of you have heard the term DSRIP? Okay, there's a few. Okay, it's another mechanism that some states have used to maintain their upper payment limits, or in your case, your low-income pool. So if someone could pull up my slides. Okay. You go ahead and move to the next one. I'm going to have to scoot this over where I can see. Okay, just as a little bit of background on the states that have adopted the Medicaid expansion, just to give you a little bit of background on the eligibility, the income eligibility levels for adults. And what the ACA did is primarily expanded coverage for childless adults. That's the largest population that has been impacted through the ACA. So prior to ACA, the eligibility limit was 108%, and it's been raised to 138% of the federal poverty level. And for an individual of one, that's a little over $16,000 a year. Next slide. And when you look at the adult eligibility limits, what you see on this slide is where states are covering adults currently today. So if you look down, it's kind of hard for me to see. I believe Texas is like next to the last. We're at about 19% of the federal poverty level. And then if you go up just a little bit, Florida is a little bit higher. And I'm sorry, I can't see what the actual amount is. It was something like 43%, something along that line of the federal poverty level. So in these expansions, if Texas were to consider a Medicaid expansion, we would be taking that population from 19% of the federal poverty level to 138% of the federal poverty level. Next slide. And when you look at the current status of the states that have made their Medicaid expansion decisions, the orange are the states that have not elected Medicaid expansion. And if you see, that pretty much covers a lot of the South. What I would say for Texas, our legislature has just come into session for this year. I do not anticipate that we would do a Medicaid expansion. However, there may be some discussion about a private coverage expansion. Next slide. So Medicaid decisions in the South. We just focus on our southern states. The southern states make up more than 1/3 of the U.S. population and are more than likely to be uninsured. There are 4 million uninsured adults in the South. They have poverty rates that are above the national average. Medicaid eligibility levels are low, and the coverage gap disproportionately affects more people of color. So that just kind of gives you a broad demographic challenge of some of what the southern states are dealing with as they think about health insurance coverage. Next. And one of the states that I want to talk about, I know that Elliot Fishman was here a little bit earlier, and he also talked about some of the states that had gotten the Medicaid expansions and some of their activities. But Indiana is the latest state that has gotten approval. It is a Republican governor, and they were able to do a few things that have not been done otherwise. And what I would say about, if I go back to my days of being Medicaid director, when you ask CMS, would you cover this? The response is always going to be, that's something we can talk about, or that's something we will consider. When you're in your building stage, most of the time they're not going to just draw a line in the sand and say, no, we're not going to do that. But for Indiana, they'd been working on it for several months. It was approved in January of 2015. It's called the Healthy Indiana Plan. It covers nearly all adults from 19 to 64 years of age, up to the 138% of the federal poverty level. It's about 350,000 clients, and Indiana calls it their consumer-driven health plan, and it is administratively complex. Now, your waivers are complex, whether you're doing a waiver for Medicaid expansion or whether you're doing a waiver for DSRIP, and I'll talk about that a little bit later. Next. Indiana is different from some of the other waivers as it prevents non-medically fragile clients above the FPL from re-enrolling for 6 months if you don't pay your premium. So a significant piece of Indiana's plan is the premiums have to be paid before you become eligible. There is a less generous benefit package for clients at or below the FPL who do not pay a premium. To receive a more generous benefit package, the clients must pay premiums of $1. And that includes your lowest income individuals. So 0 to 5% of the FPL is about $589 a year. And they still have a premium of that $1. Clients and the client is not eligible, I mentioned that earlier, they're not eligible until the premium has been paid. The way it works under Medicaid, once you make the application and you're determined eligible, then you begin to participate. Another thing that might be interesting to some of the hospitals in the room, in the Indiana plan, there is no retroactive coverage. And so for those of you that participate in that, if you've got a client that came into your facility, they were not Medicaid eligible at the time, you serve them, they were released, they go apply for Medicaid, it goes back 90 days. In the Indiana plan for the expansion, there is no retroactive coverage. And then they're also going to test a graduated copayment for non-emergency use of the ER up to $25. There'll be a study that will be done along that. And that $25 is 3 times over the federal law amount. Next. Indiana also includes a health savings account. A number of years ago, that was one of the things that was fairly popular. So they've included health savings account. The delivery system is through capitated Medicaid managed care plans. They also waived the non-emergency transportation for new clients. And in one of the other states, I'm not remembering now which one it was, non-emergency transportation was another item that was not continued. And then they're also offering optional Medicaid premium assistance for newly eligible adults with employer-sponsored insurance. So they're certainly going to be pursuing that third-party insurance. What was not approved, which I think is important for this group as you begin to think about what you want to do from this date forward, what was not approved in the Indiana plan that was asked for is work referral as a condition of eligibility. CMS did not approve that. And they also asked for a waiver of the EPSDT benefits. Is everyone familiar with EPSDT? No? They are preventive and screening for individuals under the age of 21 that are mandated services. It's also, the state has to provide all medically necessary services, whether it is in your state plan or not. So waiver of EPSDT benefits was not approved. And then just as the financing of it, the financing of the Indiana plan was cigarette tax revenue and hospital assessment fees. That's how that waiver is going to be financed. Next. Some of the other states have looked at alternatives to Medicaid expansion models. But some of the common features of the non-traditional proposals is reliance on the private insurance market, exemptions from current Medicaid rules on cost sharing, benefits, time limits, and work requirements, an emphasis on healthy behaviors and personal responsibility, and limits or contingencies on the expansion, including ending the expansion program if the federal government reduces its enhanced matching rate. So as you think about, if this is the direction you choose to go, if you think about developing this model, those are some of the key themes that other states have used in their waivers. Next. Okay, before I go into DSRIP, are there any questions about the state's expansion, things that they covered, didn't cover, things you might have an interest in on whether you think it would fit or not? Any comments from the audience? Any questions? Okay. Another mechanism that states have used primarily to protect their upper payment funding. In Texas, we call it UPL, upper payment limits. In Florida, you call it your low-income pool. And Texas is one of the states that has implemented a 1115 waiver using DSRIP. And DSRIP is Delivery System Reform Incentive Payment. And how you get paid is by identifying projects with metrics and milestones, and when you meet that milestone, then you get reimbursed. So it's an incentive payment for improving the health care of the population. So DSRIP is a part of the 1115 waiver. It's one of the mechanisms that the states can use. You can design your DSRIP project in a number of ways. Some of the early states, California, I think even Massachusetts, and maybe even New Jersey, their focus was on your traditional public hospital systems. New York and Texas has taken it a little different way. I can tell you more about Texas. I have worked with the state side as well as more so on the provider side in the implementation of this waiver. I currently have clients that I provide day-to-day assistance to them on their waiver. Initially, it was more focused, I said earlier, on safety net hospitals as a way to finance the hospital care, and now it's a more far-sweeping set of payment and delivery system reforms. And in Texas, we actually have 4 provider types that can be included in the waiver. I think we were probably maybe the first one that moved out of just it being hospital only. So it includes your hospitals, public and private, and your rural hospitals, academic institutions, local community mental health centers, and public health departments. Those 4 entities can be providers within the broad network. And what has been especially helpful is in most states, the funding of behavioral health is limited, and this has given an opportunity use to actually be able to match the GR funds that go in, general revenue funds that go into those organizations for them to be able to expand care, set up crisis stabilization centers and things along that line. Next. So the states that currently have DSRIP waivers is California, Texas, Massachusetts, New Jersey, Kansas, I got Mass in there twice, and New York. New York did something a little bit different and were a little more organized in the way they put it together. They had a lot of their decisions made prior to them rolling it out, but what they require is it's still led by a hospital, a public hospital, but then they have to bring in all these other organizations as a part, ancillary professionals, to be a part of that system. And collectively, those individuals, those organizations must meet the milestones and metric. In Texas, it's still a little bit of, the most important thing was protecting those UPL dollars and making sure we still had that money coming into the state, so it's not as quite integrated as CMS would like for it to be, and I expect in our next round that will be a significant piece of the requirement. The funds are tied to meeting performance metrics. I had shared that with you. There is a robust data collection and reporting requirements, and if I could offer any advice, and you choose to go this route, I would encourage you to have dedicated staff to keep up with the protocols, the policies, the data collection, the data reporting, all of those things. It can be, and it has been in Texas, a significant additional administrative burden for the providers. There are 4 main areas that CMS puts these projects into. It's infrastructure development, system redesign, clinical outcome improvements, and population-focused improvements. And if you're population-focused, it's going to be working with those health departments, and maybe it's a campaign on the measles. That might be one that would come up now. It wouldn't have come up a year ago. But those are kind of your 4 main groups that your projects fit within. Next. The waiver still has to be budget neutral, which means you don't spend any more money than you would have spent if you were not doing this particular waiver. There is a lot of negotiation with CMS between your Medicaid agency and CMS and your leadership offices, especially the governor's office. They do need to be actively involved. And then in concept, the states undertake initiatives expected to save Medicaid funds and then use the expected savings for the new investments in the delivery system reform. States that have the DSRIP waivers as a means to continue receiving the Medicaid funds for supplemental payments to the hospitals. Next. And this is an example of some of the projects that come out. And I know when I initially got involved in this waiver work and the DSRIP type projects, they use a lot of words that I didn't know how to put them into practice. So I was trying to show you an example of some projects. So one might be expand primary care capacity. So depending on how your state chose to set it up, but let's say that's one of the projects you selected. Well, then to expand primary care capacity, as a hospital, if you have a rural health clinic or you're affiliated with an FQHC, then the hospital may want to fund another physician to work in that outpatient setting. And so your metric is that, or your milestone is that you're going to improve capacity by hiring more physicians, longer office hours, building a new clinic, things along that line. And then you have metrics tied to each of those activities. It's how you're going to do it, and when you're going to do it, and what are you going to achieve by doing that. So you have to base, I'm going to hire 3 doctors in 2 years. And then you have to report that information. Another one some of our hospitals have used is implement a chronic disease registry, and they've created the registry, but then other providers within the community can continue to use the same registry. Technology-assisted services to support and enhance behavioral health. That's a big one for us. The use of telemedicine might be another project. Enhancing service availability, this would go into adding hours, building clinics, things along that line. The use of palliative care programs. Some of the hospitals have also used this care transition program to make sure that their discharge planning activities are set up in a way that can be successful for that individual when they return home. That they've got their DME that they need, and if they need in-home care, they've got that set up, things along that line. Another one hospitals have used is conduct medication management. That has been a big one. And then not only the hospitals, but also the academic institutions, the community mental health centers have used the patient navigation program. Health departments have also used that one for screening and notification and things like that. So what I would say is when you move into an 1115 waiver with a disrupt project, you have to do something and prove you did something in order to get the money. The money no longer falls from the sky. And that is the direction CMS is moving. So if you were to go that route, you'd want to know there is increased administrative responsibilities and there is accountability, and the money doesn't flow until you've met your expected milestones and metrics. So I'm going to stop there. If you have any questions on DSRIP? Yes, sir.
Linda, I'm curious, you talked a lot about the DSRIP part of the Texas waiver, but not much about the UC, part, the uncompensated care part of the Texas waiver. And I mean, from a hospital perspective, we're a lot more concerned about how we fund uncompensated care than the other quality projects that we might be forced to do. And so I guess what's your perspective on kind of the fate of the UC pools longer term, and what the lessons we could take in Florida from those negotiate moving forward as we try to address uncompensated care as well?
Okay. Uncompensated care is still a part of the waiver, and it's a 5-year waiver. So let's say uncompensated care might be at 80%, so you continue to get that money just like you always have, but it's 80% of the pot, and 20% is in DSRIP in the projects. And over the years, UC comes down and DSRIP goes up. So by the end of the 5th year, what's negotiated for Texas is a 50-50, 50% UC, 50% DSRIP funds. However, because Texas did not expand Medicaid, we have not seen the anticipated reduction in UC that CMS would have liked for us to have achieved. So when we get ready to go back to renegotiate, that UC pool amount will be one of the topics for conversations. But starting out, that was the way it was. We negotiated 80-20, and then maybe the next year it was 70-30, so it kind of went down, and then until it became a 50-50 at the end of year 5. So you still have UC funds, you still have your quality incentive groups, and that fluctuates over a period of time. So you'll probably want to pay attention. Texas has to submit in September 2015 either our renewal or an extension of the waiver, and you may want to, because I'm not sure how much time y'all have with your LIP pool. I'm not sure what your timing is on that, but UC is still there, but it does decrease over time under this particular scenario. Yes, I do. Maybe a lower amount, but yes, I do think it will. And I think I said this earlier, I don't expect Texas to expand Medicaid. I'd be surprised. But they might do some private option type activity. It's too early right now in the session to know where that's going to go. Any other questions? Okay, I'll be happy to answer others later.
Thank you, Linda. I'm going to be brief and open it up to other questions and discussions. Unless, John, would you like to come up here and both of you could actually come up, and we can have a public health managed care session. Several things. We discussed some of this stuff just a couple of weeks ago in a mayor's conference in St. Petersburg that some of you attended, where the mayors of St. Petersburg, Tarpon Springs, and Clearwater came together to endorse a proposal that many of you are aware of, that you've heard a lot about today, that brings the industries of Florida, and the public and private sectors together to recognize that it's time that we thought about doing things differently. Now, it's been time to do things differently for a long time, but until the financial pressure imposes itself on those of us who are providing services, training physicians, nurses, pharmacists, physical therapists, and public health professionals, and people in the community who are trying to hire workers and workers themselves who are trying to sustain their own health, it doesn't really activate our political awareness and consciousness to act. It's happened. And among the things that it's probably helpful not to do is talk about Medicaid expansion in the state, any better than it's good to talk about that in Texas or many of the other states. It's not Medicaid expansion, so we have to stop using that word. But we can use other words to talk about improving the health of our communities, improving access to, use of, and management of quality care, because healthy communities and healthy workforces are productive communities, productive workforces. They are assets to all of us. And if we look at it from that corporate model, whether we're in the public or the private sector, Florida has only things to gain by assuring that we can do everything we can with joint ventures between the public and the private sectors to make quality healthcare services. And by quality, I just don't mean good CT scans and good bypass surgeries. By quality, I'm talking about appropriate healthcare services, to keep people healthy, to intervene early on, to reduce the use of unnecessary hospitalization, inappropriate ancillaries, inappropriate pharmaceuticals. As you all know, and you've heard me say this before, we spend more than anybody else in the galaxy, and we get less bang for the buck than anybody else does. We spend more on hospitalizations, on ancillary services, and on drugs, and our people are not getting the benefit of the expense that we have. So we have to find ways to stand back a little bit and structure in terms of the way we build the system and the way we pay for it, so that the appropriate incentives are there, not just to the hospitals, not just to the managed care industry, not just to the public health system, but to each of us as citizens. And part of what the proposal that we are hearing about, that is not Medicaid expansion, includes is a bit of skin in the game, similar to what's happened in Texas. And unless we have skin in the game by hospitals, by physicians, by managed care organizations, by financial service organizations, and by employers, and by individuals, each of us, not just as patients but as citizens, it's going to be just a gimme. And we're going to get more of the same. It can't be just about expanding existing benefit programs, because all we will get from that is spending more and getting poor results, while our population, despite the extraordinary progress that we've made in public health, particularly under Dr. Armstrong these last few years, it's really cool things, immunization rates, wonderful things we've done, teenage pregnancy rates, we're still getting older, sicker, and fatter. And it costs us money. Florida's Medicaid program is now managed care, and that includes long-term care, which is a real challenge, I think, for a lot of us. And building in those structural financial measures and incentives for safety, quality, measurable outcomes, and you saw examples of measurable outcomes. Indiana and other states have done important things that we can learn from. We don't have to rediscover the wheel, but we have to put them in place in words and functions and processes that are funded that make sense. We don't always do that. That includes optimizing existing community resources like FQHCs and community health centers. The current Medicaid program that is managed care also includes a couple of really cool things that I think we need to remember. One of those that hits close to my world is the requirement that managed care organizations contract with the university and medical school practice plans to provide care and services in their community. But it's not just contracting with those important organizations. if we're going to expand access to necessary and appropriate services for the highest risk populations that we're paying for anyway, and we're usually paying more for them in the back end, we should also consider using those public and private funds to enhance the way we train healthcare professionals going forward. As part of the model. And John, you experienced it going through medical school, going through residencies, as the system was changing. And what we're looking to do is change the way we train physicians and deploy physicians, change the way we train nurses by bringing them into interdisciplinary care systems. And that has to be part of the incentive that the state, if it's going to put more money into the healthcare system, needs to encourage, if not require. But all of you in the private sector as well have to help do that. It's what will make healthcare system better. Interdisciplinary care teams where we do things innovatively, like recognize the value of clinical pharmacists in care management and reimburse them for it either directly or as part of bundled reimbursement programs. The value of clinical pharmacy in care is extraordinary. We all recognize, but we're not really paying for it, and because of that, we're not able to attract the smartest, best, brightest, talented people to pharmacy programs, nor to medical schools, nor nursing schools, nor physical therapy programs. There are other career options for them. We need to make these things important investments of our communities, and we also need to keep the medical students in the state by getting more residencies. This is, you talk about Medicaid expansion, this is part of health care in Florida. And it's part of making health care in Florida work for all of us, not just for the medically indigent, not just for people in nursing homes, and not just for people who are served by public entities. Because we're all paying for it directly or indirectly, and we all have an obligation as citizens, as healthcare providers, as taxpayers, to make it more efficient and effective. The political will to do this is something that many of you are going back to Tallahassee to address. John, you live in it every day. And it's a delicate rope to walk for those of you who live in Tallahassee. And I can only encourage you to keep your doors open and your hearts and your minds open to the possibilities of change. Despite what the political rhetoric might encourage us to do, we have a distinctive opportunity in Florida to do what is best for the citizens of Florida. But it doesn't have to be a giveaway. It shouldn't be. It has to be based on personal responsibility, measurable costs, measurable outcomes, and the line that I use when I close a lot of my presentations is, you'll all remember Superman 3. Remember Superman 3? Where Superman brings Lex Luthor back to the prison, to the penitentiary, after Lex Luthor almost destroyed the world. And he brings him down, and he plants him down in the center of the courtyard, and the prison warden says, "Superman, how can we ever thank you?" Remember what Superman said as he was flying away? What did he say? John? He said, "There's no need to thank me, warden. We're all in this together." And we are. But let's not forget that we are. And as I said just 2 weeks ago, this is like a church. You know, and you have a bunch of us who've been coming to you yesterday and today and preaching to you about stuff. About public health, about quality, about outcome, about cost, about different models, and you get all excited about it a little bit, and then you let it go. We can't afford to let it go any longer because it will affect us, it will affect our lives, it will affect the lives of our children, our families, and our communities. And it really is about community and public health that makes a difference. That can only happen with each of you and the organizations that you represent. And one last final thought about improving health and expanding appropriate services and benefits. This is one of my old lines as well. If you haven't recently, go into your local public schools and see what they are feeding our kids for breakfast and lunch. You want to make a difference, change those menus. Use your corporate, your individual, your political influence to change the menus, the things we are feeding our children. Put physical education back in the school, not online, where it is in many schools. And let's get people moving and get people working, and that's how Florida healthcare can actually work. So, is there any questions, comments? Derogatory thoughts? Yes, ma'am. Can you wait for the mic so I can hear you? Sorry. And it could be for Linda or for me.
Hi, I'm Ann Skorlik with Florida Legal Services, and just some thoughts and comments about skin in the game. There's over 30 years of solid public health research that for very low-income populations, cost sharing, premiums and co-pays can really deter people from getting health services that we really want to incentivize people to get. And so I just wonder if you had any thoughts about reconciling all that with your comments about skin in the game.
Well, Texas has a $1 premium, and that's in concept skin in the game.
Actually, it's Indiana.
It's Indiana, I'm sorry.
We don't have cost sharing.
I'm a big fan of cost sharing at some level. I think that we're a country that recognizes the value of things, and that value is measured in terms of dollars, not necessarily in terms of good deeds. We like good deeds, but we like to get value in terms of dollars. And you're right. We have 30 years worth of really good research that indicates that for the most at-risk financial populations, having them pay cost shares for medications, for primary care visits, and for other essential services doesn't really work. And we could probably get, I think we can get over that. I mean, the Affordable Care Act and many states have said for those kinds of services, if you need them, you get them without a cost share. That's a policy issue, and it's something that you can work in, and it makes sense. You don't want to deter people, because even for $1, you don't want to have to deter them, but you do want them to have a sense of responsibility, however we can impose that into their lives.
Thank you.
We're going to have you bouncing up and back the room. We've arranged this in advance so we can get some exercise.
So when you kind of play all this out for the next 3 to 5 years, what do you see happening in these states that have effectively 2 different Medicaid programs? And I mean, a state like Indiana, which is going to have its HIP, but then the base Medicaid, or a state like Pennsylvania or Michigan that have different programs, or what we may do in Florida. And so how do you think that ends up? Do you think we end up weaving the programs back together? So we end up having unified programs, or we just have one program that an adult is in, and then when they become a parent, they transition back to the old Medicaid, but then when their kids are 19, they go back into the new Medicaid, and then when they have a baby, they go back to the old Medicaid, and how do you see that working out over the next 5 years once we get past the debate over whether to expand or not?
Well, if you've seen one Medicaid program, you've seen one Medicaid program. There are basic requirements that each state has to meet, but beyond that, states have the flexibility to design the programs. But if your specific question is because their income fluctuates, they may go from regular Medicaid to the new benefit alternative package, et cetera. Those are the kinds of things that would happen. But generally, your Medicaid program is still the same as it is today. You're just managing that program differently because your services are the same, the population you cover is the same. It's just how you go about doing that. And part of it is the emphasis on being healthy and promoting personal responsibility and those kinds of things. But you can set it up to where individuals can transition from one program to the next. I'll use CHIP, Children's Health Insurance, as the example. You may have a child who the parent's income is too high for them to qualify for Medicaid, so they're in the CHIP program, and then if the parent loses their job, then they would flip back over into the Medicaid program. So that's fairly consistent with the way the program works today.
That is the point, the CHIP program. In Florida, it looks as if the Children's Medical Services program is going to be transformed. We're not certain what it's going to be yet, but we're talking about addressing our most vulnerable population, if nothing else. We may not be able to do all of them under one apparent umbrella, but it makes sense to do some carve-outs where we know that we manage kids' health differently than we manage adults' health. They require different doses, they require different services, they require different devices, different ancillaries, and different specialists. So if we're going to dismember CMS, we might want to consider taking that population of kids and putting them under a component of Medicaid or an adjacent something so that we continue to manage their care appropriately so that when they get older, they're not sicker. And to the extent that we can learn from the way other states have woven these things together, as crudely as it may be, we can learn from those things. We're not going to be able to build the machine that works right the first time. And Linda and I were discussing before we came down here, so many of us in so many of our states have had the problem of building the locomotive and designing it at the same time while we're building the tracks to take it to where we think we're going. And we're forced to do that because of the complexities of the political and economic system we live in. But that doesn't mean that we can't look to Indiana, to Texas, to New York, to California, and learn what structurally works. But culturally, Florida's a different place from Indiana. Politically, it's a different place from Indiana. And we have to take those things into consideration. We have half-cent sales tax districts throughout Florida that Phyllis Buzansky and I created 25 years ago. The Hillsborough County Healthcare Plan is the shining example of that, the Robert Wood Johnson model for how you develop a community-based system of care for the working uninsured. And we have like 25 or 30 of those things in the state, and they all operate a little bit differently. And they provide extraordinary care and services to people who would not otherwise be able to qualify for Medicaid or Medicare or anything else. If there is an expansion, those things may have some of their funds taken away, may have some of their patients taken away, but those levels of need are going to exist. And we have to constantly tweak it and constantly tweak the system, which means we have to stand back and have relevant, valid, useful, and timely data about what we're doing, how we're doing it, when we're doing it, which is why EHRs are so important, interoperability is so important, and electronic health information exchanges are so important. But it's no wonder that physicians and patients are wary of those things. Patients are wary of us watching what they're doing and having data about them leaked. It's happened. It happens if you use your credit card at Home Depot. And physicians are horribly, horribly worried about having the federal government and managed care plans and the state have real-time access to what they're doing and when they're doing it. But the fact is the train's left the station, it's going to happen, and we're going to have those data. We need to be able to use them constantly, and as Thomas Jefferson admonished us, we have to be constantly vigilant and standing back to make sure that the system doesn't get out of hand, and that we as citizens in the private and public sector manage it carefully and judiciously. So there's no single answer. We're going to trip and fall, we're going to cut our knees. Kids and old people and sick people are going to go without care. Other people are going to go getting too much care. But there's no reason why we can't learn from what others have done, carve out, manage, and put together where it works. And then 15 years from now or 5 years from now, it may change because of the way we provide health care. And much of the way we provide health care in the future is going to be virtual. Not just in terms of looking at people and doing a consult. And not just in terms of the kind of cool robotics that Steve Klasko introduced to a bunch of us a few years ago. But to actually intervening, managing, monitoring, providing care. We do it with wound management throughout the state now with Medicare and private insurance. More and more of what we do in healthcare is going to be through this hospital,